The number one use of flare hawk in my practice is for adjacent level disease. The fastest growing segment of my practice is adjacent level disease. As a whole, in spine surgery, we have about 15 to 20 plus years of good solid fusions, which have led to an increased risk and rate of adjacent level disease with stenosis. There's a lot of ways to solve the adjacent level stenosis problem. You can do it from a lateral approach. My problem with that is that I don't get to verify and have direct decompression of the neurologic structures. And generally, when I'm operating on these patients, the adjacent level is severe, they failed conservative care, and they need a direct decompression from a posterior approach. So we end up opening the prior incision and extending it superiorly and performing an adjacent level laminectomy and decompression. But that area is always very scarred, and we don't want to retract those roots that are already tight and scarred and tethered below the level of our dissection. So this small flare hawk implant that goes in very, very small can easily be placed with minimal retraction of the neurologic elements and then deployed both into lordosis and widening and distraction of that disc space. That does a number of things for me to have that type of an implant. Number one, it opens up and maintains the foraminal decompression. Number two, I get the lordosis, which gives me the alignment that I'm looking for in that adjacent level disease. And number three, it gives me a large breadth of cross-sectional area within the disc space that is then backfilled with bone, and that increases my fusion rate. In the particular patient that we're looking at today, she had had a prior lumbar fusion up to the L3 level, and 2-3 had become severely stenotic over a number of years, maybe 10 to 12 years. You can see here from our preoperative films the severity of the stenosis.